Surgical ventricular remodeling for congestive heart failure. When BB and AK are not enough. May 18, 2006. Jeffrey Maragil. Malik Masad. Heart failure introduction. Major health concern in U.S. Affects 4.8 million people in U.S. 400,000 new cases each year. Anticipated increase in incidence and prevalence as population ages. Introduction. Significant progress has been made in the medical management of patients with heart failure. However, the surgical management of patients with end-stage heart failure has evolved in a less structured fashion. Introduction. Heart transplantation remains the ultimate treatment for heart failure. Introduction. Cardiac transplantation is currently the only established surgical approach, excluding AVR and CABG, for the treatment of refractory HF as listed in the 2005 ACC/AHA Heart Failure Guidelines. Introduction. Cardiac transplantation is currently the only established surgical approach, excluding AVR and CABG, for the treatment of refractory HF as listed in the 2005 ACC/AHA Heart Failure Guidelines. Small number of available donor hearts. Inapplicable in older peds or those with comorbid conditions. Number of heart transplants reported by year and location. This figure includes only the heart transplants that are reported to the ISHL Transplant Registry. As such, this should not be construed as evidence that the number of hearts transplanted worldwide has declined in recent years. Need for heart transplant hash of potential recipients that can benefit from OHT. Heart transplantation. Actuarial survival, 1982 to 2000. Half-life equals 9.1 years. Conditional half-life equals 11.6 years. N equals 52,195. Adult heart transplantation actuarial survival by diagnosis, transplants, 1 1982 to 6 2001. Survival was calculated using the Kaplan-Meier method, which incorporates information from all transplants for whom any follow-up has been provided. Since many patients are still alive and some patients have been lost to follow-up, the survival rates are estimates rather than exact rates because the time of death is not known for all patients. The half-life is the estimated time point at which 50% of all of the recipients have died. Survival rates were compared using the log-rank test statistic. Who should not be offered a heart transplant? Irreversible PHTN or pulmonary parenchymal disease. Irreversible renal or hepatic dysfunction. Severe peripheral or cerebrovascular disease. IDDM with end organ damage. Coexisting cancer. Non-compliance, addiction. Elderly patients, approx greater than 70 years. Surgical ventricular remodeling. Other surgical treatment options are needed since transplants limited by available donors, suitable recipients, surgical treatment of heart failure, coronary revascularization in ischemic cardiomyopathy, mitral valve repair in patients with dilated cardiomyopathy, left ventricular assist devices, LVADs. Resynchronization therapy. Total artificial heart. Reconstructive cardiac surgery. 2005 ACC/AHA Guidelines. Alternate surgical and mechanical approaches for the treatment of end-stage HF are under development. Chronic heart failure in the adult, ACC/AHA 2005 Guideline update for the Diagnosis and Management August 16, 2005. Surgical remodeling for heart failure. Theory behind treatment. History of procedures. Ischemic. Baptista. Left ventricular aneurysmectomy. non-ischemic, cardiomyoplasty, current and future LV reconstructive procedures, door procedure, non-ischemic, acorn and myosplint. Conclusions. Theory. Systolic HF leads to an enlarged LV volume to maintain stroke volume. This leads to increase in wall stress due to Laplace's law. Stress equals pressure x radius divided by 2x wall thickness. The ventricular geometry becomes less ellipsoid and more spherical, leading to progression of left ventricular dysfunction and worsening heart failure. Theory. Removing or excluding portions of the dysfunctional myocardium returns the left ventricular cavity to a smaller chamber with more normal geometry. This should improve cardiac work efficiency and theoretically should improve heart failure symptoms. Ideally, it would also translate into prolonged survival. Theory. In the 1990s, studies showed a relationship between LV size and mortality. Theory. 382 patients with NIHA 3 and 4 LV size measured by EDV/PSA. LV size was a predictor of sudden cardiac death. LVs greater than 4 cm/m2 had a 2-year survival of 49% compared to 75% if less than 4 cm/m2. Independent of disease and %F. Lee Th et al. J. Cardiology 1993 72 to 672 to 676. Surgical remodeling for heart failure. Theory behind treatment. History of procedures. Ischemic. Batista. Left ventricular aneurysmectomy. Non-ischemic. Cardiomyopathy. Current and future LV reconstructive procedures. Door procedure. Non-ischemic. Acorn and myosplint. Conclusions. Batista procedure. Batista procedure, also called the partial left ventriculectomy, PLV. Developed by Dr. Anders Batista, Brazil, in 1996. Partial left ventriculectomy, Batista operation. Removal of a section of the left ventricular free wall, between both papillary muscles and extending from the apex to the mitral annulus. Remaining free edges were reapproximated and stitched together. Mitral valve and subvalvular apparatus were either preserved, repaired, or replaced. Partial left ventriculectomy, Batista operation. UIC. Partial left ventriculectomy, Batista operation. Initial experience with the Batista procedure demonstrated an initial increase in LV, reduction in heart size, and improvement in clinical functional status. However, of 120 patients, Batista reported a 22% operative mortality and 2-year survival of 55%. Partial left ventriculectomy, Batista operation. Late fatal arrhythmias plague this procedure, forcing the use of concomitant implantable defibrillators. Therefore, the Batista procedure has fallen out of favor and is no longer considered to be an appropriate option. Surgical remodeling for heart failure. Theory behind treatment. History of procedures. Ischemic. Batista. Left ventricular aneurysmectomy. Non-ischemic. Cardiomyopathy. Current and future LV reconstructive procedures. Door procedure. Non-ischemic. Acorn and myosplint. Conclusions. Left ventricular aneurysmectomy. The first successful surgical correction of an LV aneurysm occurred in 1957 by Dr. Bailey. Done without off-cardiac bypass by placing a clamp on the base of an aneurysm and passing suture beneath the lying excision of the aneurysm. Left ventricular aneurysmectomy. Dr. Denton Cooley performed a resection of an LV aneurysm 1 year later on bypass, which remained the standard for nearly 30 years. Left ventricular aneurysmectomy. A 2004 ACC/AHA task force concluded that it is reasonable, classier recommendation, to consider aneurysmectomy, accompanied by coronary artery bypass grafting, CABG, in patients with a left ventricular aneurysm in the setting of an acute ME who have intractable ventricular arrhythmias and/or heart failure unresponsive to medical and catheter-based therapy. Surgical remodeling for heart failure. Theory behind treatment. History of procedures. Ischemic. Batista. Left ventricular aneurysmectomy. Non-ischemic. Cardiomyopathy. Current and future LV reconstructive procedures. Door procedure. Non-ischemic. Acorn and myosplint. Conclusions. Cardiomyoplasty. Cardiomyoplasty, also referred to as dynamic cardiomyoplasty. Surgical therapy for dilated cardiomyopathy in which the latissimus dorsi muscle is wrapped around the heart and paced during ventricular systole. Cardiomyoplasty. Carpentier and Jacques performed the first successful surgery on a human in 1985. Cardiomyoplasty. Symptomatic improvement occurred after cardiomyoplasty. Mechanism for improvement is unclear. Pacemaker synchronization was critical for obtaining optimal improvement. Cardiomyoplasty. 600 patients undergoing this procedure found that, over time, the operative mortality decreased from 31 to 3%. Improvement in NIHA classification occurred in 80 to 85% of hospital survivors. However, long-term outcome data with cardiomyoplasty are limited. Cardiomyoplasty. A large, randomized clinical trial of cardiomyoplasty was initiated for NIHA Class 3 heart failure patients. Plagued by lagging randomization and marginal overall clinical improvement culminated in the premature termination of the study. Cardiomyoplasty. It appears that those who can survive the operation do not need it and those who need it, cannot survive it. Liar, CV. Cardiomyoplasty, is it time to wrap it up? J.M. Cole Cardiol 1996, 28 to 1181. 2005 ACC/AHA Guidelines. Although both cardiomyoplasty and left ventriculectomy, Batista procedure, at one time generated considerable excitement as potential surgical approaches to the treatment of refractory HF, these procedures failed to result in clinical improvement and were associated with a high risk of death. Chronic heart failure in the adult, ACC/AHA 2005 Guideline Update for the Diagnosis and Management August 16, 2005. 2005 ACC/AHA Guidelines. A variant of the aneurysmectomy procedure is now being developed for the management of patients with ischemic cardiomyopathy, but its role in the management of HF remains to be defined. Chronic heart failure in the adult, ACC/AHA 2005 Guideline Update for the Diagnosis and Management August 16, 2005. Surgical remodeling for heart failure. Theory behind treatment. History of procedures. Ischemic. Batista. Left ventricular aneurysmectomy. Non-ischemic. Cardiomyopathy. Current and future LV reconstructive procedures. Door procedure. Non-ischemic. Acorn and myosplint. Conclusions, LV reconstruction for ischemic cardiomyopathy. Door procedure, also called endoventricular circular patchplasty, IVP, is an approach to surgical reconstruction in the setting of post-infarction aneurysm formation, first reported in 1985. Advantage to aneurysmectomy is in an attempt to restore left ventricular geometry. DOR procedure for ischemic cardiomyopathy may be considered in patients with symptomatic aneurysms as defined by heart failure, angina pectoris, systemic embolization, and/or malignant ventricular tachyarrhythmias. DOR procedure for ischemic cardiomyopathy. Purse string stitch round a non-viable scarred aneurysm to minimize the excluded area. The residual defect is sometimes covered by a patch made from Dacron, pericardium, or an autologous tissue flap. DOR procedure for ischemic cardiomyopathy. The remaining aneurysmal scar is closed over the outside of the patch to give additional stability to the repair. The result is a more normal left ventricular chamber geometry and overall function. DOR procedure for ischemic cardiomyopathy. The operation shortens the long axis, but leaves the short axis length unchanged, producing an increase in ventricular diastolic sphericity while the systolic shape becomes more elliptical. DOR procedure for ischemic cardiomyopathy. The first 661 patients. Overall operative mortality was 8%, urgently 16.3 versus 6.2% when planned. LV less than 20%, 17 versus 1.4%, FULV greater than 40%. Japan J. Thorac, Cardiovasc Surge 1998 May, 46.5, 389-98. DOR procedure for ischemic cardiomyopathy. 495 patients available for follow-up. There was dramatic improvements. Overall LV improved from 33% versus 50% at 1 week postoperatively, maintained at 1 year. The end diastolic volume index decreased and symptomatic heart failure status, 212 pints, at 1 year, improved in 92%. In addition, 91% of patients with spontaneous ventricular tachycardia were free of arrhythmia at 1 year. LV reconstruction for ischemic cardiomyopathy. At present there are 4 variations of LV reconstruction are used excluding the septum. Linear closure by Jartine. Modified linear closure by McLebra. Circular closure with a path by DOR. Circular closure without a patch by McCarthy. LV reconstruction for ischemic cardiomyopathy. First randomized trial of surgical ventricular restoration plus CABG versus CABG alone for ischemic cardiomyopathy was published April 2006 of Journal of Cardiac Failure. Journal of Cardiac Failure Volume 12 Number 3 2006. LV reconstruction for ischemic cardiomyopathy. 74 consecutive patients with ischemic cardiomyopathy and F less than 35% with LESV greater than 80 ml/m2. LV reconstruction for ischemic cardiomyopathy. Limitations. Non-blinded. Excluded more than 2+ MR or other significant valvular heart disease. Dyskinetic, ant wall. Non-viable ant wall on thallium testing. LV reconstruction for ischemic cardiomyopathy. LV reconstruction for ischemic cardiomyopathy. LV reconstruction for ischemic cardiomyopathy. STIC trial. NIH-sponsored trial to compare medical therapy versus CABG for patients with CHF and F less than 35% including SVR plus CABG as a treatment arm in patients with LVSV greater than 60 ml/m. 600 patients scheduled to enroll. Considered criteria for surgical repair. Anteroseptalmy, with dilated left ventricle, end diastolic volume index greater than 100 ml/m2. depressed LV. Left ventricular regional dyskinesis or akinesis greater than 30% of the ventricular perimeter, and either symptoms of angina, heart failure, or arrhythmias. The following are considered to be relative contraindications. Systolic pulmonary artery pressure greater than 60 mm of mercury. Severe right ventricular dysfunction. Regional dyskinesis or akinesis without dilation of the ventricle. Surgical remodeling for heart failure. Theory behind treatment. History of procedures. Ischemic. Baptista. Left ventricular aneurysmectomy. Non-ischemic. Cardiomyopathy. Current and future LV reconstructive procedures. Door procedure. Non-ischemic. Acorn and myosplint. Conclusions: LV reconstruction for non-ischemic cardiomyopathy. Cardiomyoplasty experience has led to other novel approaches to heart failure. Observations suggested that some patients benefited from the diastolic girdling effect of the muscle wrap. This observation led to the development of the Acorn device and myosplint, LV reconstruction for non-ischemic cardiomyopathy. Acorn device. Knitted polyester sock that is drawn up and anchored over the ventricles in order to limit left ventricular dilation. Preliminary data suggest that the device produces an improvement in heart failure symptoms, left ventricular end diastolic dimension, and quality of life. LV reconstruction for non-ischemic cardiomyopathy. Study of 27 pints NIHA class went from mean 2.5 to 1.7. After 1 year, there is no evidence of constriction and coronary blood flow reserve remains normal. Larger clinical trials of this device in the United States and Europe are ongoing. LV reconstruction for non-ischemic cardiomyopathy. Myosplint. 2 epicardial pads and a tension wire. 2 pads on the surface of the heart. Wire passes through the ventricle. Placed under tension to create a bilobular shape. LV reconstruction for non-ischemic cardiomyopathy. 21 consecutive patients. 9 patients received a myosplint device alone while 12 patients underwent a mitral valve repair as well. NIHA functional class went from 3.0+/0.3 at baseline to 2.1+/0.7 at 6 months, p equals 0.001. The LV ejection fraction significantly increased in the myosplint alone group, from 17.1+/-4.0% at baseline to 23.1+/-7.2% at 6 months. No serious device-related adverse events or device failures were observed. J-Card Surge. 2005 November to December, 26, S437. Surgical remodeling for heart failure. Theory behind treatment. History of procedures. Ischemic. Baptista. Left ventricular aneurysmectomy. Non-ischemic. Cardiomyopathy. Current and future LV reconstructive procedures. Door procedure. Non-ischemic. Acorn and myosplint. Conclusions. Conclusion. Ventricular reconstruction attempts to restore the geometry of the diseased heart. Several promising surgical therapies for ischemic and non-ischemic cardiomyopathy are being developed. In ischemic, some select patient may already be able to benefit from therapy. Results of the STICK trial will help and define the role or SVR in ischemic heart failure.